afternoon, everyone. Thank you to the GIS for this opportunity. So we're going to be talking about diffuse coronary artery disease and the role that CABG still plays in this entity of patients. I have no disclosures. The objectives are to define coronary artery disease, look at the syntax score and coronary artery disease, look at the strategies of management, and just reiterate the importance of a team approach to managing these patients. In terms of a definition, there is not an agreed upon definition. The severity of diffuse disease usually is evident by the length of the lesion. So we're looking at obstruction that is also involving the majority of the length of the vessel. In terms of physiological assessment, the pullback pressure of less than 0.78 is used mostly to delineate a vessel that is diffusely diseased. Now, does a high syntax score equal diffuse coronary artery disease and vice versa? So we can clearly say that most patients with diffuse coronary artery disease actually do have a high syntax score, but the reverse is actually not true. So this is an example of a patient that has a very high syntax score that does not have diffuse coronary artery disease. This distinction is very important because the management that applies to patients with a high syntax score is not necessarily going to be optimal in this specific group of patients. Now, why the conversation about diffuse disease? Because the prognosis is worse, the revascularization is challenging, the symptom burden tends to be higher in these patients, and lifestyle modification becomes a very key player in managing these patients. These are just a few studies that have looked at PCI in this group of patients as compared to focal disease, that have looked at physiological assessment, and the most evident conclusion is that they don't behave similarly. Physiological assessment is more challenging in these patients, and post-PCI physiological testing tends to show suboptimal results. Now, we need to answer the question is, who are these patients? They're usually diabetic, chronic kidney disease, a lot of comorbidities, and they tend to be elderly. Now, we're going to consider these scenarios. If we have two patients with the exact same pathology, so let's say they're both diabetic, they both have CKD, ejection fraction is the same, functional capacity is okay-ish. The gentleman on the left is 78 years old, and the gentleman on the right is 40 years old. I think this is the problem that we face now more often with these patients with diffuse disease, is that the severity of the disease is so great in a younger group of patients. For an elderly patient, the decision to go down the medical intervention route becomes a very easy decision compared to those who are younger patients, where we need to do more in an attempt to improve survival of these patients. So in addition to the comorbidities, we need to know presentation. We need to know the burden of symptoms. Is this patient in constant chest pain? What's the territory at risk? And respect what the patient accepts in terms of risk. So the conversation we need to have with these patients are not similar to those that we have with most of our patients, quoting a risk of less than 1% with CABG, and it's a bit different because the mortality in these patients tends to be higher, and the survival is lower than their counterparts with focal disease. In terms of PCI, the evidence is conflicting. However, we know that this group of patients will need longer stents, they will need more metal, and this puts them at risk of in-stent rethrombosis and periprocedural MIs. The other risk that needs to be clearly stated is incomplete revascularization. For a lot of these patients, we'll not be able to completely revascularize. Endarterectomizing one vessel is not similar to doing all three vessels, so residual ischemia is a real risk when it comes to managing these patients. Now, in terms of endarterectomy, for most surgeons, we know that whenever we do endarterectomy, it's most commonly an incidental happening. So you go into the OR, you're trying to place your graft, and you open the vessel, and you're not able to actually get into or get vessel lumen. This is where you consider doing an endarterectomy. There are multiple meta-analyses and observational studies that have looked at this, and the conclusion is not clear. Some are in favor, some are very neutral, and a few have shown increased risks with this particular procedure. This is a paper that was produced from the STS database, and where they looked at more than 1 million patients from the year 2011-2019. They looked at operative mortality and perioperative MI and long-term outcomes in these patients, and they concluded that exactly what we expect and know. Mortality is higher in these patients. Post-procedural MI is higher in these patients. But the authors of this paper specifically concluded that the risk is not prohibitive. So they concluded that this is still a valid option in a lot of patients who require CABG, especially our younger group of patients. Again, we see the long-term revascularization is similar once you pass the 3-year mark in these patients. This is a paper that came from Japan. They included 188 patients where they performed endarterectomies to the LAD with only patch using either the ITA or the RITA. And they concluded in this paper, they looked at angiographic patency. Patency was good at pre-discharge, about 96%, and 92% at 1-year follow-up, which are very encouraging results. However, the problem with this was that the way they assessed diffuse disease was not based on imaging, it was an intraoperative finding. So whenever a surgeon ran into trouble trying to bypass these grafts, they deemed this as diffuse disease, and so it's not clear what they quote as diffuse disease in this. So other techniques is what most of us do. So you open the vessel, we tend to open a larger incision, put the ITA or whatever conduit you're using only on that, in that area, trying to tack the plaque and avoiding its movement. This is another paper from Halifax that looked at diffuseness. Their conclusion was there was increased mortality in both primary and reoperative CABG in this group of patients. Now, in terms of decision-making, we know the guidelines. There are very specific guidelines for high syntax score. There are guidelines for multiple comorbidities. There are guidelines for low ejection fraction. There are there's a lot of language, but diffuse disease is not one of them. So this makes it a bit more challenging to decide. This paper was published in the Netherlands in 2025, and interestingly, it looked at the behaviors of interventionalists and surgeons when it comes to managing patients with diffuse disease. And it concludes that even when the lesions are deemed physiologically significant, there was always a delay in patients with diffuse coronary artery disease, which reflects the real-world practice that we perform every day. Now, CABG is still a good option for these patients, no question. I think it's technically more challenging, and there isn't a single management strategy that's going to be good for all. And the heart team approach is the way to go in all these patients for sure. I think we need a more uniform language to be able to describe these patients and standardize assessment. And I think we're going to see more of planned coronary endarterectomies versus, oops, I'm already here, because we're seeing patients in their 30s with very diffuse disease, and I think this is going to be something we're going to use. Utilization of functional tools in order to guide CABG. There isn't evidence for CABG in general. There have been a few studies that have looked at this. Very few have suggested benefit over angiographic assessment, but I think it's worth a look in these patients. Arteriografts are another thing to be looked at in diffuse disease. The only issue is that we tend to shy away whenever the vessel is horrible from using, especially the radial, but they provide a protective physiology for the native vessels. So I think it's worth revisiting. A hybrid approach may be the way to go, and less metal, more balloon may be the way to go also in terms of PCI for these patients. Thank you.